Good afternoon, everybody. Thank you so much for joining us today. We're just going to give it a few minutes for people to trickle in. It's just a minute past 2, so we'll be with you shortly. All right, maybe we can kick off. Just say start with welcoming, and people can keep coming in because I know we had a few more registered participants. So good afternoon, everybody. My name is Tammy Phillips. I am based at the School of Public Health at UCT in Cape Town, and I'm super excited to be kicking off this On the Move knowledge exchange session. This has been in the works for quite some time, and the collaboration started and sort of got juices flowing towards the end of last year, and it's just amazing that it's coming together. So thank you all for being here. I just briefly some housekeeping. Please stay on mute while the presenters speak, just to avoid any disruption. We will have an open discussion and Q&A session at the end of the seminar. So you're welcome, as you have questions, to post those in the chat or make a note of them for yourself if you'd rather unmute and chat with the presenters at the end of the session. But we'll not take questions as we go through the presentations. The seminar is accredited for 2 general CPD points, so you should have captured your HPCSA number on registration, but we'll also ask for it. If you missed that, we'll ask for it in the evaluation form. And please do complete the evaluation form to help us plan future sessions. We've got 4 sessions in the pipeline and are very keen to make them as responsive to the needs of this hopefully growing community thinking about mobility and healthcare access. So just a little bit of background to the On the Move collaboration. This started with myself and Claire Keane and Kai Tram, who can maybe wave. The 3 of us are co-PIs on this project called On the Move, and really stems from our individual passions and interests in thinking about continuity of HIV care, and also thinking about how we understand mobility and how geographic mobility intersects with how people access healthcare services. And we managed to get a very tiny seed grant from the University of Oxford, and we're in the process of running a research project that is moving towards co-development of solutions to support mobile individuals to continuously access services. Around that research work, we're also doing some very intentional work around equitable collaborations, and that's partly where these knowledge exchange seminars have stemmed from, is this idea that we really want to create spaces for dialogue between both academic and non-academic partners, community partners, as well as sort of global north, global south expertise. So this is the first of those sessions, and we really hope this will be the starting point of many other discussions. Our collaborators at the moment come from UCT, University of Oxford, University of Washington, as well as the City of Cape Town and the West Cape Department of Health, and civil society organizations as well. And later on, you'll meet Amelia, who is joining us. To just introduce you briefly to our speakers, they'll introduce themselves as we go. So I'm Tammy, I'm chairing this seminar today. We also have Jabulile Zuma, who is a patient representative who's going to share her story with us. We have Kai Tram from the University of Washington, who's going to share from the research perspective what we know about mobility and access to HIV services and continuity of care. We have Megan Hurling, who's a clinician with the City of Cape Town, who's going to share from the provider perspective. And then those three individuals, along with Amelia Mfiki, who's the director of Ubumi Betu, an advocacy organization, as well as Claire Keane, who is a South African clinician now based in Oxford, will have a panel discussion to talk more about some of the issues that come up from the seminar. So I think without further ado, we'll go into our first section of the day, or maybe I've kind of run through the agenda already. And following the panel discussion, we'll have an open Q&A. And as I said, do hold your questions for that. So without further ado, I'm going to hand over to Jabulile, who's going to share her story with us. I'm going to shift here so that she is the center of attention. And maybe I'm going to stop sharing my screen actually, so we can just see you. There we go. Over to you, Jabulile.
Okay, good afternoon, everybody. Is my voice okay? I've got to turn this. Okay. I am a woman of 59 years old, married, have children. I discovered that I'm HIV positive in 2018. So it means I'm about 8 years old on this virus. Oh, in that time of the year 2018, I was unemployed. I was a home dweller, staying at home, looking after my children. So in October 2023, I received a call from my sister who was working in this province, Cape Town province. Me, I'm from another province. So she said there's a work on this site. So without preparing myself, I just jumped off and take a bus and come here at Cape Town without preparing myself. So when I found out during my interview, I found out that I was supposed to start my job immediately. So I didn't bring anything for me, especially my treatment. So I start working here. When I come here, I don't know anybody. It was only my sister. Unfortunately, we don't living together with my sister. The work is on another area, and then she's working in another area. So I need to get my treatment. And then at that moment, she didn't know my status, my sister. So I need to tell her that I need this treatment because I can't default my treatment. And then she said it would be easy if I find the health facility on my site where I'm working. So where I'm working, I don't know these people that came to work with them. I'm new from them. I was so scared to tell them about my status. So, but luckily there was a lady who was older than me. So I sit down with her and talk to her. And then she advised me that she can find out the place where I can collect my treatment. Luckily there was a health facility nearby where I'm working. She talked to them and then I went there. And then when I went there, they need a transfer letter. The problem started. I don't have a transfer letter. I didn't plan to come here, as I told you before. So, but I asked them, and then they said they can't help me without a transfer letter from my side, where I came from. So I said to them, because I don't have treatment, but I'm willing to bring the transfer letter to them. They can help me. to give me treatment because I can't afford to default my treatment. Luckily, the health worker who was working there, she helped me to give me medication just for that moment while I'm waiting for the transfer letter from my side. So I called my family that side, my husband that side, to find the letter from my local clinic where I was used to collect my treatment. He went there, and then they were not good on the side to give him a letter for transfer. They want me personally. So he failed to get the letter on the first day. The next day, my daughter went there. She was so strong because she fight for that letter until she gets it. Even though they want me personal, she told them, I can't be there to collect my letter because I'm far from where am I now. So luckily they get the letter and then they come back. And then they help me in the facility clinic with that letter. While I was waiting for the transfer, the registered nearby clinic gave me treatment. Yeah. So I continued to continue to take my treatment, even though I didn't produce the transfer letter. As soon as I received the transfer letter, I go back and then they open the file for me. It's where I started everything on the right way. But they helped me at the beginning with my treatment. So I find out it's very difficult because I was not prepared. If I was prepared I'm going to move that side to this side, maybe I will make all the arrangement earlier on before I came to this side. That's a problem I had, but at the present moment, everything is going well. Thank you.
Amazing. Thank you so much, Jabulile, and I just want to really express our appreciation for you being here and being willing to share your story. It's really, really helpful for us to understand really the intense lived experience of some of these challenges, and also what works, and how really empathetic both social support within your family and the health providers enabled you to continue your care. So thank you for sharing that. I'm now going to hand over to Kai, who's going to share with us from a research perspective. So Kai, you can share your screen, and I'm going to mute on the side.
Great. Thank you, Jabulile. Does that look okay?
All good. Thanks, Kai.
Okay. All right. So I'll just keep my camera on for the introduction, and I might shut it off, but I want to welcome everyone and say good afternoon. Thank you for coming today. I'm really happy to get this opportunity to talk about a topic that I find really interesting and stimulating from an academic perspective, but at the same time represents a real challenge for people engaging in care, whether or not they have HIV, but maybe particularly so for those with HIV trying to stay on treatment. So just briefly, I'm a physician scientist at the University of Washington in Seattle. I take care of patients in the hospital and see patients with HIV at my weekly clinic. I've been coming to Cape Town about once a year since 2010. I'll take the next 20 or so minutes to talk about mobility and HIV, mostly from a research perspective. No conflicts of interest on my side. This talk is motivated by two observations. The first, that mobility is very common. Most people experience some sort of mobility. It's a fact of everyday life for a large number of patients. And secondly, mobility can be a primary driver of both risk of infection and treatment interruption for HIV. This is an outline for my talk. First, I'll give an introduction into mobility data, what it is and why do we care. Next, I'll introduce what I call a mobility research agenda. And then I'll draw some connections between mobility and HIV specifically. And then lastly, time permitting, I can talk a little bit about the Sesacona study. It's sort of on the bleeding edge of mobility research, but we'll see. These are learning objectives for my talk. Hope by the end, you'll be able to describe what we mean by mobility and the different ways to measure or quantify it, understand associations between mobility and HIV, and then gain some ideas about how it could be useful in improving public health interventions. So what do we mean when we talk about mobility? This can be the geographic movement of individuals or populations. Mobility can occur across many different scales of distance, for example, within a neighborhood or across borders, and time perhaps. For example, maybe our daily commute or periodic travel, perhaps longer term migration. And some people are constantly on the move. You might think of truckers or fishermen, and others may be moving only during certain seasons of the year. For example, visiting family back in the Eastern Cape. And then there's just the daily short-term mobility that almost everyone will experience, going to work, going to the shop, coming home. And with regards to HIV, mobile populations have been found to be at increased risk of treatment non-adherence or treatment interruption, being lost to follow-up, having worse virus suppression, and greater mortality. There's also an association between risk of HIV acquisition, so infection, in those people with higher mobility, for example, migrant laborers or minors, and then rural to urban migrants. And then mobility has also been studied in the spread of drug-resistant strains of TB and malaria and other infectious diseases as well. So in South Africa in particular, migration and HIV have been closely intertwined since the beginning. There are high rates of internal migration and cross-border migration, rooted in sort of historical policies, especially with the aim of ensuring laborers for gold and diamond mines. We all know this history. There are high rates of circular migration continuing into the present day, linking urban areas with rural communities. And if you look at sort of census data, you see that 1 in 5 residents right here in the Western Cape were born elsewhere and made their way to Cape Town and the surrounding areas. So many people travel frequently between provinces. This is analysis quantifying internal migration and short-term mobility across districts in South Africa. We use some data from the 2022 census, which is a 10% sample, to construct migration flows between districts. This is between 2011 and 2022. So individuals who reported a change in their residence were classified as migrants. And so for each district, we calculate the total number of migrants. We found a national incidence of internal migration of 2.7 per 100 residents, and that corresponds to approximately about 1.6 million internal migrants during this period. So on the left of this diagram, this depicts migration between districts. Each district is represented along the outside of the circle with arrows linking districts representing the flow of people. And the thickness of each arrow is proportional to the total number of migrants. Here, we're just highlighting in red, the red arrows, just extensive migration to and from Johannesburg. But, at the bottom right-hand side of the circle around 4 or 5 o'clock, that's where Cape Town is. And you can see arrows pointing to and from the Eastern Cape, which we all know. And so on the right-hand side of this diagram, we're showing short-term mobility, and this is estimated from a national travel survey in 2020. And it's the proportion of residents reporting overnight travel, so spending 1 or more nights away from their house or home. There's a lot of heterogeneity between districts. For example, nearly half of residents in Johannesburg will report at least 1 overnight trip, compared to about 1% in the bottom ranking district. And really the main takeaway here is just a significant amount of movement between districts, whether it be short-term travel or changing your residence. And both kinds of mobility, you can imagine, may affect your ability to engage in HIV care. What does this look like in particular for the Western Cape? These are maps from an older paper, which uses data from 2001 and 2011 census, analyzing about 300,000 migrants to the Western Cape. And these are where they came from other provinces in South Africa, and not necessarily migrants from foreign countries. In this analysis, they identified 3 significant clusters of origin for migration, these being the Eastern Cape, where about a third of migrants to the Western Cape came from. Gauteng was 21%, and a third from eThekwini and Nelson Mandela Bay. And the study also looked at the demographic characteristics of migrants. They found that younger age groups made up the largest fraction of the migration stream, really peaking between ages 25 and 29. Those from the Eastern Cape were generally younger and in search of employment. And those from Gauteng were maybe older and looking for different lifestyles. And these came from other cities, so this was urban migration. And these are all people moving to the Western Cape. Okay, just to step back for one moment here and think about mobility conceptually. An important question to ask is whether you're thinking about mobility of individuals or populations, because these will be measured in different ways with different kinds of data. If we take populations, for example, this is the mobility of large numbers of individuals. You can easily see this through sort of mobile phone data. There are these things called call data records, which are routinely collected by mobile phone companies. It's basically a timestamp of a phone when it's in range of a cell phone tower. And then there's GPS location data, which is collected passively on smartphones with higher spatial resolution. You can also get some of this information through census data, which we just showed, and travel surveys and demographic and health surveys. The figure here is from this paper looking at the use of mobile phone data during the COVID pandemic, and just illustrating that mobile phone owners are only a subset of the population. So some people don't have mobile phones, and so they wouldn't be captured by this type of data collection. You may also think about mobility on the individual level and individual risk of disease and care engagement. Thinking about things like exposures and travel motifs, activity spaces, metrics of mobility, and just the ethics of collecting data like this on the individual level. I'll plug this really nice review article on measuring mobility by Leah Khalifa. It's a literature review of mobility-related research and how these things are measured in different contexts and different populations and geographies in relation to HIV outcomes. A really nice article. Okay, so this leads me to the concept of this mobility research agenda. There was this commentary in JIS in 2023, essentially posing 3 questions. First, what aspects of mobility matter most for HIV care outcomes? Like, can there be high-risk mobility that can be used to facilitate targeted interventions? And then secondly, what groups are most vulnerable to treatment interruptions? Can we identify these mobile groups within the general population? And third, what interventions would actually improve HIV treatment outcomes for mobile folks? So it was along these lines that I began to think about this mobility framework more generally. I think there's compelling reason to think about public health through a mobility lens. I'll tell you what I mean by that. Firstly, just defining the measures of human mobility, like I mentioned before. What are the empiric measurements that we have? What are the data sources? Is there a standard definition of mobility, and how do we characterize it? You can think about it at the macro, meso, or micro levels. At the macro level, how do people move on a large scale? For example, migration, changing residence. We can get that through population surveys and census. At the meso level, it's sort of circular seasonal migration, maybe labor related. And then at the micro level, just individual movements on a day-to-day basis. You can see that through GPS devices or smartphones. And importantly, how do you harmonize various approaches to measuring mobility to improve comparability between future studies? How do you know if you're talking about the same things? Secondly, how does mobility influence public health? Does it increase your risk of exposure? Does it increase your risk of infectious contacts? Can it increase or decrease your access to healthcare and treatment? And then what about the role of contact networks and social networks? Can this data be used to predict an epidemic or offer insights into how to optimize treatments? And my final point is, what can we do about it? Mobility is intrinsic to the human experience, but what are the implications in terms of inequalities in health for certain populations or groups or in certain geographies? And how does understanding this aspect of HIV epidemiology inform public health action? It's really sort of a cross-cutting line of inquiry, overlap in terms of geospatial analysis and understanding human behavior and health systems. So how do we better measure it and define it and use this data to improve interventions? Okay, so getting back to HIV specifically, one caveat is that I won't spend much time here making a case that disengaging in care is bad and leads to poor outcomes. I just want to illustrate sort of more broadly the geographic breadth of mobility in the form of clinic transfers. And this occurs on a regular basis, like we just heard. There's an assumption here that this creates a challenge for engaging in care, as we heard from Debule, and as many of you already know from your clinical practice, when you see a patient that's newly transferred. And then secondly, I'll talk about mobility affecting the risk of getting HIV in the first place, not just engaging in care. This is a study looking at retention in HIV care in South Africa using lab results, those being CD4 counts and viral load testing. This is from the National Health Laboratory Service. By using some matching techniques, the authors are able to create a national HIV cohort that captured whether patients were receiving care at different clinics, because obviously all of this data would show up in the NHLS system. So in effect, this accounts for patient transfers between clinics. They found a national retention of around 63%, ranging from 74% in the Western Cape to 52% in Mpumalanga. Mind you, this was in the period of 2006 to 2012, so a while ago. And depending on the province, between 1/3 to 2/3 of patients actually moved clinics at least once, and 50% of patients overall transferred clinics at least once during this study period. I'm highlighting the Western Cape here, showing almost 60% of patients in the Western Cape move between clinics. So this clinic transfer that we're talking about, the majority of them moved to other clinics within the Western Cape. So they stayed within the province, but for whatever reason went to another clinic. The study in JADES looks specifically at mobility and clinic transfers among postpartum women. So over 1/3 of women initiated ART during pregnancy and were initially thought to be lost to follow-up, but actually continued care elsewhere. 2/3 of those continued care in the same province. This is in Gauteng, while 1/3 continued care in a different province. But interestingly, those who stayed in the same province were out of care longer and had lower CD4 counts on re-entry. So perhaps there are some substantial barriers to retention and care that could influence its decision to, quote unquote, shop around for local clinics. There's a reason that they didn't go back to the initial clinic. Tammy Phillips, who's here, most of you already know, conducted similar work on postpartum women here in the Western Cape. So among around 600 postpartum women who initiated care at an integrated antenatal clinic, about 1/4 never linked to care. And then of those who did, they accessed care at close to 100 different clinics around the Western Cape and even farther afield. And many of these people also attended multiple clinics when they actually linked to care. And then similarly, this is a study using PHDC data on patients from Klipfontein Health Subdistrict, documenting all their encounters to the end of 2016. And there are actually 237 unique sites visited by patients on ART throughout the region. 2/3 of patients here also transferred clinics at least once during follow-up. And most of those transferred to other facilities within Cape Town. 20% transferred just within the same sub-district. And then the median distance between clinics where people showed up was 8.6 kilometers. So remember my two claims. I think for now, I've provided some evidence of the first claim that mobility is very common, both at the population level and also among those in care for HIV. And then maybe I'll talk about the second now. So switching gears, I just wanted to make the case that not only does mobility affect care engagement, but also the risk of infection in the first place. And these are some seminal studies on the effect of mobility and or migration on the risk of HIV infection across different settings. Notably, these are led by Carol Camlin and team in Kenya and Uganda, and in South Africa by Frank Tanzer and others in the Africa Health Research Institute cohort, that's in KZN. In this publication, Camlin reports findings from a population cohort just measuring mobility in Uganda and Kenya. So in a sample of 2,300 adults, there are really large differences in the forms of mobility across the regions between men and women and also by HIV status. And here, labor-related migration was especially pronounced for women living with HIV. You can see that these people had an adjusted relative risk of HIV infection that was 2.3, so relatively high. This is a systematic review and meta-analysis of 29 studies. It found that HIV acquisition was more prevalent among migrants compared to non-migrants. There's an odds ratio of 1.69. And then within the RE cohort in KZN, specifically among female participants, these authors found an overall high migration intensity. So if you migrated more than twice a year, this is associated with increased HIV risk of a hazard ratio of 2.8 compared to those with low migration intensity or not moving around so much. I really love this study by Adrian Dobra that geolocated over 8,000 migration events for 17,000 individuals who are HIV negative at baseline. This is between 2000 and 2014. And what really strikes me is that the distance and range in which people, even from this relatively tiny study area, would migrate to over time. So they obviously went across the entire country. And just using some Cox proportional hazards models, they quantified the relationship between migration and the risk of HIV. What's remarkable here is that they were able to quantify how HIV increases with distance. And they showed in their analysis that the risk of HIV infection increased by 50% when men traveled a distance of 40 kilometers and women traveled a distance just over 100 kilometers, holding all other factors equal with each other. And so my claims here are that there's also evidence for mobility being a risk factor for HIV infection. I think with the time remaining, I'll just describe a study sort of on the bleeding edge of mobility and HIV research, moving from the population level to individual level movements. This is a Sesicona study. Maybe some of you know it, but it's trying to understand the risk of HIV infection among young adults at a very granular level. And so this took place in KZN, where there's a very high HIV prevalence. It's where the Accra Health Research Institute maintains this population cohort that's been followed for over 2 decades. But overall aim was to look at specifically young adults who are at high risk of HIV. And the objective was to understand the relationships and the mechanisms that would place young adults at such high risk, combining population level data and then high resolution smartphone GPS data. This enrolled around 200 young adults between 20 and 30 years old. And then between 2021 and 23, participants received a smartphone with a customized app or installed the app on their own devices, and their locations were recorded every 30 minutes and sent to a secure study server over a 6-month period of time. And we were analyzing this data for movement patterns that might place people at high risk for HIV. This is just a study timeline. I'm not sure if Tulele is on this call, but she was instrumental in sort of leading this. And this is enrollment procedures, starting with the phone call and inviting people to join, visiting patients at home or participants at home, and going over the study protocols in the app. And I'll just mention here that in the first phase, participants received study phones. In the second phase, they could just download an app to their own personal devices. And that location data was collected and sent to servers. There's so many challenges with doing this type of study with battery life and broken phones and touchscreens and things requiring troubleshooting. So probably the biggest factor is just having folks keep the study app on just because data is so limited. Critically, I just want to mention that Tulele really did a lot of groundwork in terms of focus groups and building out an ethical foundation for this study. You can imagine ethical issues here with privacy and data concerns and monitoring of locations. So I don't want to gloss over this section, but I just encourage you to read this article, which touches on many of the issues here. So what did we find from the Sesicona study? These are just preliminary results that we reported in an abstract. Firstly, just mapping the GPS locations from 1 to 200 participants. What really struck me was just how far people traveled over a 6-month period of time, ranging across all provinces, even in all major cities, all the way to Cape Town, just from this tiny rural community. And then even within the local site, there's a lot of extensive local mobility. And here I just overlaid some GPS locations with some jittering to protect privacy, but showing the areas of the study site that are traversed by participants. Some just key findings: there's over 27 million locations collected, so lots of data to study, but these are distributed across 57 different municipalities across South Africa. There are about 130 days in the study area and 17 days outside. Most people have left the study area at least once, and there is both internal and external mobility. And then many people spend time in places with high HIV prevalence, even if they didn't live there. Some questions that came up that deserve ongoing analysis, just characterizing these movement patterns. Are there specific types of patterns or typologies? And then what are associations of mobility with areas of high HIV incidence? I'm not going to go through these other analyses. These just follow on projects based on the Sesicona data, looking at activity spaces and travel motifs, trying to understand sort of the fundamental units of travel. And then ultimately understanding the contextual exposure to HIV and how this can inform HIV prevention interventions. So just to conclude this section of the talk, in the context of a rapidly evolving HIV epidemic, mobile individuals continue to be at high risk of acquisition of HIV. Young adults display highly dynamic patterns of movement, and we need to just ensure that we have tailored interventions to reach these groups. And then key takeaways overall in this talk, I hope I've convinced you that mobility is very common across all of South Africa, including the Western Cape. There are different ways to measure mobility, be it GPS or surveys or routine healthcare data, and that these capture different dimensions of mobility. And then finally, that improving understanding of mobility can help to optimize care we provide for patients living with HIV and then those at risk for HIV as well. And so I'll end there and just make a plug for our website on move.net. I hope you check us out. Thanks.
Amazing. Thank you so much, Kai.
Sure.
That was, yeah, what an incredible overview of the state of the field. Thank you so much. Thank you to those who have already started posting questions in the chat. Please continue to do that, as we will definitely get to them at the end of the session. So if you've got questions for Kai, please post them or hold on to them so that you can unmute later and ask him directly. We're going to move to Megan now. I'm going to share your slides. Megan, we're sharing them from this side. You should be able to see that. So Megan is the clinician with the City of Cape Town. I'm going to hand over to you to further introduce yourself. Thanks, Megan.
Thank you, Tammy, and good afternoon, everyone. My name is Megan Hurling. I am a medical doctor working for the City of Cape Town, specifically at Delft South Clinic. And I will be presenting on a program that we use in the Western Cape. Sorry. I will be presenting on a program that we use in the Western Cape called Single Patient Viewer, or SPV, and how this supports continuity of care in mobile populations. So you can go to the next slide. As previously mentioned in Kai's presentation, population mobility is increasing, and patients move for various reasons, namely employment, housing instability, family responsibilities. They move for education. What we see quite often here is that they move for seasonal work and migration between provinces. So the clinical consequence for us is that patients often receive care from multiple facilities over time. You can go to the next slide. Looking at mobility and healthcare engagements, patients face many challenges once they move between facilities. They often miss their appointments, they have treatment interruptions, their records are often lost, they have duplicate folders being made and repeated investigations being done, and they have difficulty transferring care. As I stated in the beginning, I worked for a clinic called Delft South Clinic in the Western Cape, and one half of the clinic focuses on child health, and the other half focuses on infectious diseases, mainly HIV and TB, for both adults and children. And so the impact that we see on HIV care is that there is reduced retention in care. There are treatment interruptions, there are delayed viral load monitoring. We have an increased risk of virological failure, and this ultimately impedes the UNAID and WHO 95-95-95 target. And for those who are unaware, this goal is to see 95% of patients living with HIV know their status, 95% of those diagnosed who are diagnosed for them to receive antiretroviral therapy, and for 95% of those who are on therapy to be virally suppressed. And then mobility extends, the impact extends beyond HIV to include TB, diabetes, hypertension, and other mental health care conditions. The system challenge that we face is that historically, healthcare records were often facility-based and paper-based and fragmented. As a result, when the patient moved, the clinical history often didn't move with them. And this created information gaps, it caused delays in treatment, decision-making, and risk to patient safety. So introducing single patient viewer, or otherwise known as SPV. SPV is a clinical information platform that brings together patient information from multiple healthcare systems into a single view. So it allows us as clinicians to access lab results, pharmacy information, facility attendance history, clinical records. Sometimes we can access radiology reports, and we have access to HIV and chronic disease information. So the core principle of SPV is that you have one patient with one longitudinal record. Thank you. So how SPV supports mobile patients? The traditional model is that the patient would move and then their information would stay behind at whichever clinic they used to stay at. And with the SPV model, it now means that the patient moves, but the information remains accessible. So the benefits of this is continuity of care across facilities. We have reduced information loss. We have improved clinical decision-making, and we have a better understanding of the patient's journey. HIV care and mobility. So the common scenario that we see is that the patient often initiates care at one facility or antiretroviral therapy at one facility and then moves to a different district. And then months later, they will present to that different clinic in that district. And without linked information, the clinicians won't know what antiretroviral therapy the patient was on. They won't have access to their previous viral loads or past treatment interruptions. They also might not know about any existing comorbidities. And so SPV helps us bridge this gap. Looking at how SPV assists us across the HIV cascade, it helps us as clinicians identify previous HIV-related investigations. It helps us look at previous treatment history. We can see when there has been attendance at multiple facilities. We can access viral load results. And the patients and then patients who re-engage can be managed more efficiently. SPV and lost to follow-up. So important to note, not all patients who are lost to follow-up are truly lost. Some patients transfer silently, some access care elsewhere, and some move temporarily for work. And SPV provides us with visibility of this. So we can discover recent facility visits, we can look at medication collection, and we can look at lab tests that were done elsewhere. And this helps us distinguish disengagement from care versus mobility within the healthcare system. SPV also helps us improve patient safety. It reduces duplicate investigations, so repeated blood tests and repeated HIV testing. It reduces medication risks, so duplication of prescriptions and drug interactions. And it reduces clinical uncertainty because more information supports better decision making. The benefits of SPV for the health system. For patients, it means better continuity, it means fewer unnecessary investigations, and it means faster clinical outcomes for them. For clinicians, it means improved access to information, better understanding of patient history. And for the health system, it once again reduces duplication. There's more efficient resource use, and we have improved monitoring of care pathways. So this is just a slide to show you what SPV looks like. Once you log in with your own login details and you search the patient's folder number or you search their name and surname, you will be directed to this page, which is the patient's dashboard. And this dashboard gives you information about the patient's previous diagnoses. It gives you information about encounters at different healthcare facilities. And there you can also see information on lab tests. If you look on the left-hand side of the slide, the panel in dark blue, that's the list of tabs, and this is all the information that is available to you for that specific patient. And then I just wanted to point out on the top of the slide, there's a phone and a chat box icon. And that is the SPV function that allows us to phone the patient or send them an SMS from SPV, the system, and the patient won't have your contact details or phone you back. So that's quite handy. Thank you, Tammy. We can go to the next slide. So I'd like to demonstrate how we use SPV on a daily basis. I have one example of a 53-year-old female. She's known HIV positive and known to Delft South Clinic. She was noted to have previous adherence issues earlier in 2025, but that had improved and she was compliant with us since June of 2025. She then missed her appointment in November of 2025, and there was no transfer letter issued at this time. She then returned to Delft South Clinic in May this year, and according to her, she had moved to Piketberg in November for seasonal work and had been receiving antiretroviral therapy there, but she didn't have any referral letter proving this. So I then went on to SPV, and I could see that SPV showed monthly visits to Piketberg Clinic and Moriesburg Clinic. It also showed that the patient had been issued medication, and it also showed recent blood work. So I'd just like to show you where I got that on SPV. So if Tammy, you can go to the next slide after that one that I just had. Yeah, so this was me I went to the patient's dashboard and then I clicked on the tab on the left-hand side on encounters. And here I could then see that at the bottom of the slide from August, September, October, the patient was seen at Delft South Clinic. And then thereafter, as she said, she was then seen from November up to February this year. She was seen at Piketberg Clinic and Moriesburg Clinic. Tammy, you can go to the next slide, please. I then also looked to see, I clicked on the tab of called medicines, and I could see that the patient had then been issued her antiretroviral therapy. And you can see there, it says under dosage, it says repeat times 6. So she had been receiving the medication regularly between Piketberg Clinic and Moriesburg Clinic. You can go to the next slide, Tammy. I then clicked on lab results because surely if she was being seen at those clinics, she would have had a testing done. And I could then see that the last lab results, as the patient told me that the last time she was seen at that clinic, she had blood tests done, and she was told by the clinician seeing her that she would have to follow it up in Cape Town when she returns. So she then had her viral load done, and I could see that it was 49,190. Tammy, if you could please go back to my slide on the example, the case example. Yeah. So I was then able to, using SPV, I was then able to see that the patient was actually compliant on treatment for about a year, and that the patient wasn't lost to follow up, and that she probably had virological failure because she was still virally unsuppressed, even though she had been collecting medication. She had said that she'd been drinking it every day. And so we didn't then have to do baseline workup for the patient and restart HIV treatment like we had thought that, or like I thought I would have had to do. And I could then come to a quicker decision and say that, you know, this is probably virological failure. And then we applied for resistance testing for this patient. So key takeaways from this case is that it demonstrates that patients may be mobile, but not necessarily lost to follow-up. We spared this patient unnecessary investigations and blood workup, and we came to a quicker clinical decision and outcome for the patient. We had, for this case, we had applied for the resistance testing and it was accepted. She qualified for it. I'm still awaiting the outcome or the results from that. So we can move on, Tammy, to the next case. The next example is a patient that my colleague saw at our clinic. It's a 4-year-old child known to Delft South Clinic with HIV and TB, known to have poor compliance. The child was then lost to follow-up. And we attempted to recall the patient via SPV using that call and SMS function, but we were unsuccessful. She then saw on SPV, there's in the tab you can look at follow-ups, clinic follow-ups and other encounters. She then looked at that and saw that the child had visited Ceres Clinic and received antibiotics there, but no HIV or TB treatment. She then called Ceres Clinic and informed the TB nurse about the patient and her history. And then Ceres then took the responsibility to have community health care workers visit the patient and return the patient to care. So the key takeaways from this case is just highlighting the usefulness of the SMS or calling function on SPV, and that I think that we should all get into the habit of using SPV for patients so we don't miss events. Patients don't always think it's necessary for us to know that they were admitted to hospital or had been seen at a different facility for an unrelated condition, or while they would think that it's unrelated, for us it's quite important. And SPV helps us ensure continuity of care across different facilities, for example, like silent transfers that we can pick up. So limitations and challenges. Challenges include data quality that depends on the source systems. So you may have capturing errors, and if there are errors, that's the data that you will be using. It won't be correct. Not all of the information will always be available. We sometimes have problems with connectivity and access issues, so problems with electricity and the internet connection. It's important to note that SPV is exclusive to the Western Cape, so when patients move to other provinces, that information is lost to us. The need for clinician training, people need to be trained on how to use SPV, and then also how to capture information on SPV, and then the continued importance of patient-centered care. So it's important to note that while technology supports care, it doesn't replace our clinical judgment. So future opportunities to build mobility responsive healthcare systems. It's to have stronger interoperability, to have more systems that are linked, more shared data. So if we could have more even imaging on SPV, on systems like SPV, and national patient identifiers. We have folder numbers, but we often find that patients have different folder numbers here in the Western Cape than what they have in the Eastern Cape or elsewhere up country. And so if those could be linked somehow, that would also be great. other opportunities are cross-provincial information sharing, digital health innovations, and more patient-centered service models. So the goal must be healthcare that actually follows the patient. So the key messages that I would like to share is that patient mobility is a normal feature of modern life. Mobility can disrupt continuity of care, especially for chronic diseases such as HIV. Many patients interact with multiple facilities over time, and SPV helps us create a longitudinal view of patient care across the health system. Digital tools such as SPV can make healthcare systems more responsive to mobile populations. Thank you very much.
Thank you so much, Megan. Yeah, what a lovely overview of the use of SPV, and particularly your case examples, I think really helped to make it clear. I think picking up from what Kai had said too, like mobility is normal, people are moving, and we have the tools in some ways to stay connected. I think what you said about sort of health system that follows the patient rather than the other way around, wherever they are, I think is incredibly important. So thank you so much for sharing that. We were going to keep questions till the end, but I think we should take a few questions now before we move into the panel discussion. I can see there's some activity on the chat. So if you have a question for any of our three presenters, Jabulile is here with me, or for Kai, if Kai and Megan maybe want to unmute, and we'll take maybe 3 questions, and then we'll move into our panel discussion. Or we can also look at, I know there were some questions posted in the chat. So the first question is for Jabulile. I just want to open to see the chat. Okay, so we have a question here for Jabulile. I don't know if you can read that, Jabulile. Just want to know what would happen if Jabulile did not get the transfer letter. I'm not sure if this is a question for Jabulile or for the clinicians, maybe for Megan. Would she be restarted on ART, or is it okay to check the last viral load on NHLS and transfer in based on that information? Sometimes the clerks don't want to transfer in a patient without a letter, or without knowing what prescription she was using, or your adherence from another province. So I think that's around Jabulile's story, maybe a question for Megan about what would have happened if Jabulile had failed to get the transfer letter.
Yeah, so that's dependent on which facility she presents to. And it's true what you're saying, Nontle, that some clerks, even at the access point to the clinic, if you don't have a referral letter, some people will just turn you away. At our clinic, we try our best, even if the patient doesn't have a referral letter, we try our best to use, like you said, NHLS to check the last viral load. We then have to sort of sometimes, go along with what the patient's narrative and what they are saying. But essentially, we start from the beginning. We do our own baseline bloods. We reinitiate care, and we treat it as someone who has disengaged. And is now a restart. That's what we would do at our facility.
Thanks very much, Megan. Nontle, yeah, go for it. You're welcome to unmute and ask your question.
Yes, then that is delayed care now again, because I'm starting from scratch. And I was just want to know if you've got a last viral load as a source document that this patient was in care in Eastern Cape. This is the NHLS record. Can't you use that as your source document so that you just transfer the patient in, especially if a patient is like Jabulile, knows her treatment, she's got her treatment, she can show you the treatment. Can't you write in the clinical notes, like your source is the patient had medication at hand, and you also retrieve these results, can even print the copy and put it on the patient's folder instead of restarting the patient? Are we allowed to do that? Maybe Beth can help me.
So if I can answer that, sometimes, so it depends on how how recent that viral load, those tests are, how recent the CD4 and viral load, the testing had been done. If it is quite recent, we then say the patient is likely compliant. But you can imagine if your last viral load was lower than detectable in February, and you are only presenting to our facility now in June, I have no way of understanding whether you had been compliant on treatment from February to June. And so it's like I said, we then take the patient's word for it, but we would still, to cover ourselves, we would still do a repeated viral load just to make sure that that it is as the patient said.
Yeah, thanks for clarifying that. Conrad, I'm glad to see your hand up. I was going to look at your questions. It looks like most of the questions you've posted in the chat have been answered in the chat, but please go ahead and ask your question.
All right, thank you very much, Tammy. I think it's just a follow-up from the last question, because most of my questions have already been answered in the chat. But this is around, is this process of restarting treatment, redoing the viral test and all the other tests for persons coming without transfer letters, is it for people coming from different provinces, or it still happens for people within the Western Cape? Because there's reports that state that even for people who are transferring from one hospital to the next within the Western Cape, they still face this issue where even with the presence of SPV, they are still forced to, show the transfer letters, or they restart treatment, or some are literally just sent away completely. So what are the experiences? What are the differences? Do we use SPV at least for persons transferring within the Western Cape, and maybe take our time to actually explain to the persons coming from out of the Western Cape province before restarting treatment? How does it work? I just wanted to understand better.
Thanks, Conrad. Megan, do you want to have a?
I'm not sure I understand the question. Are you asking whether we only use, could you repeat your question? I'm so sorry. I didn't quite understand.
Sorry, that was very long. It's basically it's two prongs. So for persons, I want to know if you restart the treatment process, so viral load testing and all the different tests for persons who are coming without transfer letters from out of the Western Cape province, or this holds for everyone, be it from out of the Western Cape or within the Western Cape. Because we just had a presentation on SPV, which shows that it should help continuity of care within the Western Cape province, because SPV, as I understand, is used only within the Western Cape. So does this restarting process apply only for persons coming from out of the Western Cape? And then for those within the Western Cape, do we just use SPV and not rely on transfer letters to go ahead and provide them treatment?
So no, it has to do with what information is available to us. So for mostly like you said, SPV is owned to the Western Cape and not elsewhere. So often the patients outside of the Western Cape, we don't have any baseline for them. So then yes, we are more likely to restart treatment and redo investigations for those patients. For patients within the Western Cape, we still require, it's still common practice to have a transfer out letter and a transfer in letter, and to start a new sort of booklet for the patient in at the various clinics. But often the patients move without awaiting the transfer letter or going back to the clinic for the transfer letter. It does make it easier for us to just continue their care and not restart them, because we have access to the information on SPV. But sometimes, even in the Western Cape, I mean, that information isn't on SPV, and we do have to restart the patients. Or at other facilities, we don't do that at Delft South, but I know at other facilities, patients are told to go back and go and get the letter and then return to the facility where they now want to continue care.
Thanks very much for that, Megan. I think let's take one more question from Aurelie. I think you've got your hand up, Aurelie, and then we'll move into the panel discussion. Go for it.
Thanks, Tammy. It's not really a question, it's more a comment, because I think we've been struggling with this idea of transfer letter for a while, and it's not a lack of policy. Like I posted here what's already in the policy from the 2023 guidelines, and we're going to reiterate the same policy that you shouldn't be required to have a referral letter to be restarted on treatment, but somehow in the implementation is always very different. And maybe we also need to think about when we implement policy and we train people, the clocks are never part of the training. So maybe it's also something we need to think about from our side, but any suggestions, other suggestions are also welcome. Thank you.
Yeah, thanks very much for that, Aurelie. And maybe that's a mini pitch for our next knowledge exchange, which we'll introduce at the end of the session. But in August, we're going to have a session specifically focused on sort of policies and implementation. I think that it speaks sort of across this work of at the moment, there seems to be a lot of reliance on goodwill of people who you encounter, and that perhaps not everybody is always on the same page, and where some of the challenges come in. Thank you so much for those questions. We're going to move into our panel discussion. So on our panel, we have Jabulile here with us. Thank you. Kai, who has given us a great overview of the research perspective. Megan, who's got our health service perspective and understands what's going on in the clinic. Amelia, are you online? If you're able to put your video on. I think you have come into the room, Amelia.
Yes.
You are there. Hi, Amelia.
Good afternoon.
So Amelia Mfiki, who's an advocate, a human rights advocate and director of Bomi Betu, and Claire Keane, who is a clinician turned academic. He has a lot of experience in the South African space as well. So we're going to kick off our panel discussion. I would like to ask each of the panelists to just briefly introduce sort of who you are and where you fit within this collaboration, sort of your role, I guess, what hat you're wearing in this discussion. And then any brief, maybe one or two brief reflections that you have on what has been presented so far, and then we'll move into some additional questions. So maybe Claire, I can see you on my screen, so do you want to kick us off?
Hello, everyone. So my name is Claire Keane. I am a South African clinician. I know many of you from my time in Khayelitsha when I was working for MSF, but since then I've moved to this what is currently a very tropical island of England with our heat wave, and I'm working at the University of Oxford. I think some reflections on what's been said today, firstly from Jabulile's story. I think what really stands out to me is how much burden there is on people and our patients to have to make a plan to cope, not just with HIV, not just with their treatment, but also with our system, and the backflips and jumping through hoops that people do to try and work their way around a system that is supposed to be there to support them. And so just so much work has been done, especially in HIV over the last couple of decades, in making care more person-centered. And I think we've still got a ways to go, but we're on the right track in rethinking how we design our services to make sure that they are accessible and that they don't add to people's burden, that they take away from people's burden. So that was one thought. The other is just from Kai's work is and his synthesis of all the evidence is just how much mobility there is, and it's something that isn't this niche problem. It's actually just a normal part of everyday life, and we just need to treat it as a normal part of everyday life instead of having a panic if mobility happens. It's going to happen. It's not something that we should try and prevent. It's something that is helpful to a lot of people in terms of jobs, in terms of family commitments. And so we need to make sure, again, going back to that first point, that our system can accommodate normal people's normal lives, which then links to what Megan was talking about in terms of something like SPV being a really useful way to navigate that and find a way to help our patients without adding the burden to them to have to figure it out. Hand back over to Tammy.
Thank you so much for that, Claire. I'm going to move to Amelia. Pick on the two people who haven't spoken much yet. Amelia, do you want to just briefly introduce yourself and a couple of reflections so far?
Good afternoon. And yes, my name is Amelia Mfiki. I am the founder of Ubomi Bethu, which is an advocacy organization. Most of the people in the platform will know me as the civil society chairperson in the Western Cape. I co-chair the Provincial Council on AIDS and TB with Premier Alan Weeby. Good afternoon, colleagues. I think it's exciting to have this conversation because it also talks about where we are in terms of identifying our own challenges. And the mobility is one of the things that communities have felt it very hard in most of the facilities up until we then met with different departments and particularly City and the Department of Health to say what is it that we can do. But I also want to acknowledge the efforts and all the systems that have been created in making sure that we try and close those gaps that are identified. And I also want to acknowledge that, yes, as Claire is saying, we need to treat it like that. We need to move with times. The problem with our system is that it was created then. Now we need to look at mobility as something to empower people, because people move to find families and jobs, and that on its own, it supports their well-being or their healthy lives. Now, the problem is that our system is stuck in one space, and we also need to look at people that are working in informal or seasonal jobs where they need to move frequently, and mobility is one of the things that we need to look at because of their survival strategy. And it can also improve the well-being of the person. But the question is, how do we then develop systems that move so that we are not demarcating people and asking people to and label people as lost to follow up while people are in the places that they are comfortable to be in. The other question is, how do we then address the system, the issues within the system itself? Thank you.
Wonderful. Thank you so much, Amelia, and we're very grateful to have you here with us today. Thank you. I'm going to call on Jabulile. You have introduced yourself to everybody already. Maybe some brief reflections on what has been presented today.
Thank you again. I think I find myself, I learned a lot of things today to what we're talking about today. And then the way I see things here on this side of the province, I think it's more advanced than where I came from. Because I noticed that lots of things on my side is not the same as on this side. So things are different from my province and this province. But here I find it's more advanced on HIV things. And then I learned a lot of things. And then I was so happy to hear about this SPV thing. It was very interesting about this thing. It's Dr. Megan, yes. The way you explain things, I find that, okay, I'm not in the wrong place. I'm in the right place. Cape Town. I'm learning a lot. SPV opened my eyes. So if this thing is there on my province where I came from, it was going to be easy for me to track me down on this side and find out all the information about me from that side. So, but I'm happy because they managed to help me. The problem, they managed to help me while I was new, doesn't know anything about this thing, this province, and then I was new, really new. It was my first time in this province. So, but they helped me. I didn't default my treatment because of the way they do things on this side. Thank you.
Awesome. Thank you so much, Jabulile. I'm glad you think you're in the right place. Hi, you want to go for it? Any reflections?
Just want to thank WLA for her story and commend the resourcefulness and resilience of people living with HIV just to find care and then be proactive about it. And systems should really be serving people and making it easy, but a lot of times it's not. And to reflect on what Megan said, that, you know, at her clinic at Delft South, they will go out of their way to help patients who show up, but maybe that's not the case in other places. So even though there is maybe a blanket policy not to refuse folks, that the implementation of the policy is different from place to place and from provider to provider. It really speaks to sort of implementation issues. And then this thing called street level bureaucracy, which is basically providers or data clerks have a lot of power that they can exercise in different ways to be helpful or not so helpful. And there's probably ways to address that.
Thank you so much for that, Kai. See, there's a question on street level bureaucracy. We'll come back to that. Megan, go ahead.
Right. Like I said, I'm Megan Hurling. I work for the City of Cape Town. I'm a medical doctor and I work at Delft South Clinic. And I think for me, I'm very happy and grateful that I could be a part of this panel discussion and this initiative. It's changed my view on mobility as well. Coming to work at Delft South, it's taken a long time to understand that mobility is not the issue or the problem. I find that a lot of clinicians, we get frustrated that patients have moved or that they re-engage after moving and we have no access to information. I think every clinician's frustration is getting this thin folder with no information and having to start from the beginning when the patient themselves can tell you they've been on treatment for 10 years. And that's not the issue. That shouldn't be the problem. We should rather have, the healthcare system should facilitate movement because like Jabulile said, she explained the situation and you can see from that how important mobility is for our patients. And we should strive to have a better understanding of that and understand that mobility is not the problem. It is how the health system assists with the patient's mobility that needs to be better, and we need to do a little bit better with that. Yeah. Thank you.
Yeah, thanks so much, Megan. And I think the point that you're making about the frustration on the provider side is real, and the way we think about these problems needs to consider both of those perspectives. Like, how do we also support providers to function effectively with these frustrations that are real, but also support a really person-centered approach that considers everybody along the pipeline that's needed to support continuity of care. I have a question that I'm going to frame for, I think, Jabulile, Megan, and Amelia. In your experience, what are some ways that mobility both supports health and well-being? And I think some of you have touched on this already, but also can create challenges for continuity of care. So thinking about this sort of tension between the need for mobility, but also the challenges that it creates. Maybe, Megan, you're still unmuted, so maybe you want to start.
So again, yes, the importance or the positives and how mobility supports health for our patients. It's like Jabulile said, people move for employment. It means better opportunities for them, more livelihood. Some people I see that our patients often move to the Eastern Cape or back to Cape Town to be closer to family members and to have family support. And that ultimately it improves their overall health. So that's the importance of it and why it is positive. And then we obviously see the challenges thereof when patients then, as a result of the health system not being able to facilitate that mobility, patients then disengage from treatment because it's so difficult to enter into the new facility. Yeah.
Thanks, Megan. And I'm going to turn it to Jabulile. And I particularly wondered, I think something that hasn't really come up is something around stigma. And one of the things that I thought of when we've talked about your story is how this might have been quite different if perhaps your family had not been aware of your status, or if you have been able to be open and you have a social support structure, but how that might have differed. And it sounds like you experienced that a bit here with not knowing new colleagues, not knowing who you could speak to. So maybe you can speak a little bit about that from your experience and what that means in the context of moving between places.
I think on that point is that the new environment, when you came to a new environment, you don't know anybody in that area. So you are new, you are meeting the new people there. So, but they don't know about your status. Especially for me, I was new with the new colleagues. They don't know me. So it was very difficult to explain my status to them. So I find it's hard because I need help, because I don't know anything about environment here. So at first I was so frightened to talk about my status because they are going to judge me and say, oh, she's a registered nurse with this and this and this. You know what, when you are HIV positive, some people, they think that if you are HIV positive, you are a bad thing. There are some people who are still have that kind of things in their mind. But at the end, I decided that is my life. I need to, at least one I can trust, which I can tell her about my status, even though I was not trusting that she's going to keep it on herself. No one is going to tell everybody because I don't know her. It's a new environment. That was the main problem. But as time goes on, I see that I can trust her, I can be open to her. I don't worry about my family. They will know about me, my status. The word was that in how I'm going to do with my treatment, because I just came in without preparing myself. That was the main problem. But anyway, as time goes on, I find out that it was a good idea to talk to one person who can help me and find Kuzana, who help and continue with my treatment.
Thank you so much. And it must take a lot of courage to identify that one person that you feel comfortable to talk to. Thank you, Jabulile. Amelia, so the question to you is the same, sort of in your experience, how do you think about mobility as both necessary for health and well-being, but also creating challenges for continuity of care?
Sure. Thanks, Tammy. Let me start with the challenges. In terms of loss to follow-up that I spoke about, patients may disengage when they are relocating, especially if the system requires them to re-register or waiting time is longer. We are hoping that with these conversations, we can build a system where if Amelia comes to the facility and explain the situation that was in a different facility, she is not asked to come back on the next 3 months for them to access services, or asked to bring a document that is making it difficult to bring. For example, there are people that are moving from deep rural communities to urban or to metros. So we should find a system like SPV was presented to say, this is how we are tracking your profile, and then we can then start your medication immediately after all the procedures that are done. But again, in terms of support and the highlights, I think what I understand is that it also improves access to opportunities because people relocate for different reasons, but also location can give patient access to better health quality. So as much as people will be relocating, most of the time people are relocating, yes, linked to stigma, but also identifying the facilities that are better for their own health, especially the specialized health facilities. The last one is that a transfer between facilities often lack documentation, meaning you may not have all the documents that you have, which may lead to a treatment gap. The question is, how do you then record Amelia who has approached the facility, even if she is not serviced on the day, to make sure that you build up on the system to say these are the people that need a proper service. But another question that we need to look at, how does then SPV link to the NDOH system, so that if you decide to move to a different province, you are not blocked because they do not have access to your provincial system. So yes, those are the key points that I wanted to talk about. And stigma is a big issue because some people do not want to access some facilities because of their experience related to stigma and disclosure concerns.
Thanks so much, Amelia. Yeah, you're reminding me, I was struck with Kai's presentation about the level of sort of small distance movement, local movement, and people moving between clinics and what might be driving that, which is probably not necessarily a like residence move, but perhaps a preference move or a move related to stigma or perceived quality of care and the other things that might be driving that. So thank you so much for that. I had a thought that I wanted to follow up on, and now it has disappeared. So I'll move to the next question. So we've spoken a lot about mobility in the context of HIV services in particular, and I think that makes sense for us, and then that's where we have come from in our research perspective, but also because of the resources that have been invested in HIV. It's the area where we know the most about people living with HIV and their movement between facilities and their continuity of care. We don't have the same level of data for people with diabetes or people with hypertension or people with other chronic conditions. And I wanted to ask, and any of the panel members can answer, if you have any thoughts about about how mobility is reflected in as a wider challenge in the health system, rather than what we've specifically spoken about in terms of HIV. Anybody want to? Maybe Megan, I can point it to you because you mentioned it a little bit about sort of the SPV allows us to look at other conditions as well, and not just HIV. But I guess the challenges around like the availability of data and how we think about continuity of care for other chronic conditions.
Yeah, I agree with you, Tammy. I think that HIV highlights the issue with the healthcare system and mobility, because we have more programs and systems for HIV so that we can pick up these issues earlier on. And although mobility does have an impact on other chronic diseases, I work at a different facility in Belhar as well, where we do chronic diseases of lifestyle. And we often also see patients who disengage from care, but because we don't have those same targets or programs like we have with HIV and TB, we often the patient just has to make a new date and follow up on their own accord. We aren't seeking to re-engage with that patient, and we sort of leave it up to them to come back to us. And often that then does mean that, once these chronic conditions like high blood pressure and diabetes are left untreated for a long time, the patient then does come back to us with all of the complications that we once again then have to spend more resources treating and getting them better and so on. So I definitely think it doesn't have an impact on the broader healthcare system or chronic diseases. We just don't see it like we do with HIV.
Yeah, thank you so much. Amelia, go for it.
Yes, I also wanted to share that any chronic conditions required long-term follow-up would really face the similar disruptions in the system if it's not designed for mobility. And we really need to look at how do we fix the challenges and the gaps that we're identifying in HIV, as it highlights the systems for all other chronic. And now the question is, how do we then prepare our systems in making sure that we are ready for other chronic illnesses?
Yeah, thanks, Amelia. Kai, go for it.
I was wondering for the providers if there's a lot of primary care that's done for patients during their HIV visits, or is that a separate encounter? I know for us, and at least at my clinic here in Seattle, we do a lot of primary care because it's probably the only time the patients will have contact or be in touch with the health system. So we take the opportunity to do all the other things if we can. But I was just wondering how it's set up in the Western Cape.
Megan, do you want to respond to that?
So with regards to primary care, do you mean sort of other chronic care as well, like other
Diabetes, high blood
Yeah.
pressure.
So
normal
at our facility, it works differently at various facilities. Some facilities are aimed at infectious diseases, so the patients then just come for HIV and TB treatment at that facility. And some of them also, some are preferred, but to have the other chronic diseases treatment for them to receive that at a different facility. And sometimes these infectious diseases clinics, they don't have access to the chronic information, medications that the patients need. So then the patients are forced to get that medication elsewhere. At our specific clinic in Delft South, we aim to give the patient holistic care as much as possible. So we have access to antihypertensives, diabetic treatment, but we don't have, let's say, advanced levels of treatment, insulin and other medications, because ultimately it is aimed at infectious diseases. So at our specific clinic, we try and do a holistic treatment of the patient. Often we see patients and in one visit, you'll see a female HIV positive patient who is on TB treatment, and we will do her family planning, we'll do her pap smear, we'll issue her HIV treatment, and we'll issue her TB treatment and follow her up in that sense. And one clinician will do all of that. The patient won't even have to go to different doors or different rooms to access that care. So we try our best to do all of that in one setting, and then have the patient come back on a different day or at their next follow-up, and have the same holistic treatment from another physician or clinician.
Yeah, in the case of HIV and chronic diseases, at the beginning, I was not sure where I started to visit about my HIV treatment, which they are going to help together with my diabetic. I'm also diabetic in hypertension. So when I go there, they said they are not going to help me on those chronic things. They transfer me to another facility where they can treat everything together.
Okay.
So that's what I was going to say. It was
And
like
then you got
I got all the medication in the one place, not to go to this place and then take place again. So they transfer me to another facility where I'm going to get everything together.
Yeah, this definitely speaks to a broader conversation around integration as well. Aurelie is not technically on our panel, but we give her permission to speak with our panel. Go for it, Aurelie.
Sorry, I think maybe for Kai, if you also don't know the Cape Town system so well, there's two authorities that run the clinic. There's the City of Cape Town, and Megan's from the City of Cape Town, and Jabulile also accessed a City of Cape Town clinic from what I hear. But we also have a provincial system that runs often the bigger clinics, and the system's often quite different there. So all those bigger clinics would provide NCD and HIV care, but it might be less integrated. So maybe just to clarify that. Sorry, I forgot. I'm not allowed to speak. I'm not on the panel. Sorry about that.
No problem, Aurelie. Thank you so much for clarifying that. And I see Nontle's got a question as well. Go for it, Nontle, and then I have another question for the panel.
Thank you very much. My question is to Amelia. I just want to know who is advocating for patients who are working in our houses, like the domestic workers, because we get domestic workers who contract TB and then they disengage even before they start because they are fearing that they are going to be fired by the employer. I remember there was one in Botosek that refused to start TB treatment because she doesn't have a good relationship with the boss, and the minute that the boss finds out, she's sure that she's going to fire her. And yet that boss has got children that are under 5, which I found that she needs to disclose, because these 2 children, they need to be started on TPT. But on the other side, she is scared to come to the clinic because the boss is going to know. And then we've got also those that are working in the firms, also that they are not disclosing to employers. Even if you give them a proof of attendance or a sick note, they will go to work. Remember, sometimes when they are smear positive, they are not supposed to go to work for 2 weeks. They're supposed to, some of them will go because they said, if I'm staying here with this, if I've got this certificate and I give this certificate to my boss for 2 weeks, I'm going to be unpaid. So who is advocating that? Which contacts can we go to help these patients? Because some of them are unfairly treated. Thanks.
It's an excellent question. Amelia, you to answer?
Yes. Thank you, Nonhle, for the question. This is an interesting and good question, particularly the fact that we're coming from the World TB Day that was hosted in the Western Cape. And to answer direct, within the provincial, within the civil society, we have the organized labor sector, which should be looking at employment policy and. But also in the Provincial Council on AIDS and TB, we should have a representation of all the heads of the department. And a good thing is in the Western Cape, we do have the Department of Agriculture. In that conversation, I brought in exactly what you are saying to talk about the TB in seasonal jobs. And I also mentioned the policy of no work, no pay within the Department of Agriculture. And one of the questions that I was asked is the data or the evidence to say most people that are affected by TB or contracting TB are because they are not getting to the facilities and because of all the reasons that we know, including what you are saying that Amelia will consult in the clinic and still go to work, and that compromise the client in the client's health and also spread the TB in the farm or in the spaces that those people are working in. So this is a fairly new conversation that I brought out in the council to look at how do we then make sure that Department of Agriculture or whoever is working in the farm and the organized labor are part of the conversation. And then we look at how do we make sure that, one, we provide services to where people are so that they do not have to worry about moving from their work, say, Caledon to Khayelitsha to access services. But another element that we need to look at is how do we then bring in the private sector, which is the conversation in the council right now, to say if there is a GP closer in town, Amelia does not really have to go to the clinic to access the medication. They can also provide the service closer. This is why now in the civil society and the council meeting, we have invited and we are including the private sector to make sure that these three are talking to each other. Now, the challenge is around evidence to influence the policy, but the conversations are happening. And we do have the TB task team, which include the TB champions or TB ambassadors, those who have experienced TB, and the implementing partners that are only focusing on TB program. So your TB Proof, TB HIV care and other institutions are part of that, where they are engaging further. But this is on our top agenda in terms of re-looking at no work and no pay policy and also providing services where people are. So I will also take the considerations from the recommendations from this room as well. Thank you.
Thanks, Amelia. Yeah, you've touched on something that I was going to raise next, which was around generating evidence, because it sounds like that is really key, having the evidence to support the advocacy and to support the policy change. And my next question was going to be directed at Kai and Claire, though anyone else, Megan or Amelia, please feel also free to jump in. If you had to pick one question, I guess, one gap in our understanding of mobility and engagement in care, what would it be? You want to start, Claire?
I'll let Claire go
Okay,
first.
Kai.
One gap. Oh, I don't know. I think we know a lot about why people move. I think we know a lot about, sort of what the challenges are, but maybe where we have less information that would be useful is what actually works to address it. And so maybe we are at the point now where we can move to the next step of, okay, we understand the challenge, but what do we do about it? And test out some different things. I know things have been tested before, like patient passports or, other sort of interventions, but possibly, say, for example, looking at SPV and the incredible impact it's had in the Western Cape and seeing, could we replicate this elsewhere? Or I think the other thing that is, it's probably not an easy one to answer, but is what is, someone mentioned in the chat, the street level bureaucracy, and that's sort of talking about how you've got a policy, but what actually happens in practice is up to the clinicians, the data clerks, the security guards, the people that are in between the patient and that beautifully created, well-worded policy and how it actually plays out on the ground. And sort of understanding, why the policies around transfers and the policies around, person-centered care are not being enacted, and understanding, what McGann said about mobility not being the problem, and sort of shifting that attitude to change how we see it. But also, as she said, that often there's clinicians are overwhelmed, or the facility staff are overwhelmed, and it's not coming from a bad place. It's coming from a stressed out, having 1,000 different competing priorities, and this is just the straw that breaks the camel's back place. And so what do they need? Like, what do our staff need to support them, to support our patients, might also be another place to look at addressing this problem. Hand over to Kai.
Yeah, thanks, Claire. Maybe for me, it would be from a population level, if you're able to sort of predict or anticipate who might be more likely to move, even though a lot of times it is unexpected, to provide maybe differentiated care from the beginning when a patient arrives at a clinic. That might be it, to sort of be able to make subgroups and then target interventions, because you only have a limited number or menu of options anyway. And so finding out which interventions will work for which patients is a challenge that I want to see.
Thanks very much, Claire and Kai, for that. I have one more prompt for our panel that maybe you can try to give me a brief sort of what's the first thing that comes to your mind when I ask the question, and then we'll open it up for similar thoughts, I think, from the audience, either in the chat, or you're welcome to speak out or ask additional questions. So in your opinion, what would be the lowest hanging fruit that you think we could act on tomorrow, on Monday maybe, for more mobility responsive health services?
I'm going to jump in, and I think Beth is already doing this at scale, but it's sort of longer refills, kind of having the approach of getting out of people's way. Maybe we don't need to see them every month. Maybe if we only see them every 6 months and only see them clinically once a year. We can leave people to manage their own lives, and we're here as the support function when they need us. So that would be my low-hanging fruit.
Thanks, Claire. I love that. Get out of the way. Amelia, go for it.
Yes, I think for me is that we need a mindset shifting that is designed to assume that people will relocate or people are moving, so that we face the reality, which include flexible hours, which include decentralizing access point, as I mentioned, inviting other stakeholders to be part of it, particularly the private sector in the areas where it's needed the most, staff training to support mobile and patients without stigma. My issue is mobility is not a problem, but inflexible health system is. And if we build with understanding that people will move, we'll have less challenges, including less stigma. I will end there.
Amazing. Thank you. You're getting support from the room here. Megan or Kai? Megan, oh, Kai, you go for it. And then we'll close it.
Let me jump in because I might be stealing Megan's. I want providers to use SPV if it's available. It seems like, you know, the Delft South providers do, but maybe not other places. So that seems like a very low-hanging fruit because that tool already exists. So it should be used.
Yeah, use the tools we have, right?
Yeah.
Go for it, Megan.
I agree. And I agree with Amelia as well. I think that healthcare workers, specifically at clinic level and so on, need that mind shift to understand that mobility is not the problem, and that it is the healthcare system that needs to, you know, sort of facilitate that movement for patients. I think if we get that understanding right, people will be more willing, or healthcare workers will be more willing to assist patients at the facilities. I think that for me, from a clinical perspective, the lowest hanging fruit would be just to make that initial visit or presentation to the clinic easy for the patient, without all this unnecessary administration and frustration and long waiting times to open certain documents and have all these documents readily available. I think if we could just somehow, you know, make that initial bit for the patient easier, it would help us quite a bit. Yeah.
Thanks, Megan. I just want to check if Jabulile has anything to add before we open it up to the floor. No.
I support Imeni and Clay that they make us people freedom to live their life.
Absolutely. Thank you for that. So give people freedom to live their lives. I think it's excellent. So do open, I guess, that same question or other questions up to the floor. What do others think are things that we could be doing? Please feel free to post in the chat or raise your hand if you'd like to share your perspective of what you think we could be doing to support mobility responsive health services, or to ask any of our panelists a question that is still sitting with you. Seeing any hands? No questions in the chat. Maybe our panelists have said it all. All right. Are there any last thoughts from our panelists before we close? I think Lou and Babalwa are showing. Lou is our background technical expert and Babalwa as well. So thank you for joining us. So I think then we will close on that note, which is how do we find ways to allow our patients the freedom to live their lives? And also importantly, as Claire mentioned, to support our providers to be able to do that in a relatively streamlined way, because I think there are definitely some barriers in that space as well. So accommodating to provide to our patients, but also with systems that are that are streamlined and supportive of the realities of the health services and the constraints that we work in. So with that, I just wanted to say a very huge thank you to all of our panelists for your engagement and discussion today, as well as the participants. I also wanted to just thank the other members of the collaboration. So Erica Moore-Holland from the City of Cape Town is not able to join us, but it was really a driving force behind us even getting the knowledge exchange off the ground. Beth is in the room, Beth Harley, and Erin van der Hayden, who've also just been sounding boards throughout this process. And Ntando, who's also, I'm not sure if he's on the line, Ntando Yolo. Really, we've had a lot of discussions that have led into our thinking around this. So thank you to all of you for that. And to point you to our upcoming webinar, which will be on the 28th of August, and is going to focus on policies and practice. So what do the current guidelines say? What are the policies and how are those implemented? The one thing that I remembered now what I was going to say is it would be useful if we can get someone perhaps who can speak to the HPRS, the national identifier system, would also be helpful for our understanding of sort of how that is working or intended to work. So please do register for the August seminar, and then a call to please complete our feedback form. So the QR codes are shared on the screen. We really, as we said, are hoping to host 4 knowledge exchange sessions. And so any input you have on how this one has been, perhaps things that would be useful to discuss, things that we can incorporate into future sessions. The one kind of watch this space is that we're planning to have an ethics session as well. That is focused on sort of some of the moral dilemmas that occur around the issues of transfer for providers. So that's on the radar as well. And I think with that, just a huge thank you to all of you. And I will leave this on the screen for now so people can scan the QR codes. And we hope to see you in August. So thank you all very much and have a wonderful weekend.
Thanks, everyone. Thanks, Tammy, for chairing.
Thank you very much.
Thanks, all. Have a good weekend. Bye.
Thank you, everybody.